This lecture will describe vascular access in dialysis treatment. Vascular access includes AVF, AVG, and catheter. This lecture will provide an overview of VA and AVF. This lecture will provide an overview of VA and AVF. Hemodialysis requires blood to be drawn out of the blood vessels at a rapid rate. Therefore, a blood vessel, usually near the wrist, is operated on to create a new, blood pathway, to allow sufficient blood flow. The entrance and exit of the blood vessels that once let the blood out of the body, pass through the dialyzer, and return it back into the body is called the vascular access. Vascular access for maintenance dialysis patients is almost always an autologous vascular. Arteriovenous fistula is called AVF. In this internal shunt, an artery and vein in the arm are connected directly under the skin to allow more blood to flow to the vein, making the vessel larger, and a needle is inserted into the larger vessel to remove or return blood to the body. Artificial blood vessels are sometimes applied when the patient's own blood vessels are too narrow, or when the blood vessels for AVF cannot be created by the patient's own blood vessels, such as when the patient has undergone repeated surgeries after long-term dialysis. Diabetics and elderly patients often have narrow blood vessels. The arteries and veins, which are self-vessels, are directly connected and short-circuited in the body, and blood from the arteries flows into the veins, increasing blood flow to enable hemodialysis by needle puncture of the veins. The increased blood flow dilates the superficial veins, making puncture easier on both the arterial and venous sides. The creation sites are the snuff box is called tabatiere, peripheral forearm, central forearm, elbow, and upper arm. AVF are commonly created with radial artery and radial cutaneous vein anastomosis. AVF has various forms depending on the site of construction, the vessel to be anastomosed, and the anastomosis method. AVF has the highest patency rate of any VA. AVF has a lower incidence of infection and is the first choice for VA in the guidelines. AVF are highly resistant to infection and can be used over a long period of time. AVF is at risk for cardiac overload and Steele's syndrome due to peripheral ischemia, since the arteriovenous system is short-circuited. As a precaution for AVF puncture, it is advisable to allow a sufficient waiting period between AVF creation and use. If early puncture is unavoidable, sufficient care should be taken. If you are puncturing a new and unusual site, check to see if the vessel you are puncturing is a dilated artery or an arterialized vein. AVF precautions. It is important to avoid puncture sites near the anastomosis and to select a site that does not cause problems when the arm is moved. To avoid recirculation of blood, the site of draw line should be selected on the side of the anastomosis, rather than the site of return line, with as much separation as possible between the two. In AVF, repeated puncture of the same site can cause pseudoaneurysm or shunt stenosis. So the puncture site should be shifted from the previous puncture site and the puncture should be performed as widely and evenly as possible. In the next session, we will describe AVG and catheters.